Well, aloha everyone, and welcome back to Anatomy 151 here at Chaminade University. Today we'll be covering Unit 9, Joints and Articulations. So just to give you an overview of the chapter, we'll be talking about all of the various types of joints in the body and how they are classified into those various types, and we'll talk about the different types of movement that can be carried out at any given joint. So just to give you a definition, a joint is a point of contact between either two or more bones, cartilage and bone, or teeth and bone. So basically it's a point of contact between bone and another bone, bone and cartilage, or bone and teeth. And we can classify them both structurally and functionally. To classify them structurally, we need to know if they have a joint cavity and what type of connective tissue is involved in holding these units together. And functionally, we can talk about them in terms of what degree of motion is permitted. So structurally, we can classify them into fibrous, cartilaginous, and synovial. So fibrous are going to be suture joints. So for example, when we just looked at the skull bones and the way those two bones fuse together into sutures, they're going to be dense, and they are going to be very more dense than regular bone tissue generally. And another example is gymphosis. So gymphosis is basically where your teeth are going to interact with the bone. And another example is between the radius and the ulna. So these are going to be joints that generally aren't going to be mobile. They're not going to be moving at all, really. We also have cartilaginous joints. These are generally going to be synchrogenous. We'll talk about that in a second. They're hyaline cartilage, which means that they have no motion or very little motion. Some examples of these might be like the epiphyseal growth plate, for example, or might be someplace where we have fibrocartilage that allows some movement but not much. For an example, might be like the pubic symphysis. And a synovial joint is where we're going to have the most motion. This is where we have articulating cartilage on both ends. Generally, they're long bones with a synovial cavity between them. And the synovial cavity is going to be filled with synovial fluid, and that's going to allow the articulated bones it's going to prevent the articulated bones from grinding against one another. And they're going to be surrounded by accessory ligaments. Generally, these joints are going to be freely movable, such as your hip, your knee, shoulder, elbow, etc. We can also classify joints into functional characteristics like synarthroses, which allow no movement, as I just mentioned, the suture and the gymphosis, so places in your skull where your two bones are bound together or where your teeth are bound to your jaw. There ought to be no movement at those regions. We also have amphiarthrosis, which allow very little movement. For example, your spinal column, right? You can move it, but you can't twist it in a complete circle. Or your pubic symphysis. You do have some motion in your pubic symphysis, but not a lot. And then we also have diarthroses, which are freely movable, such as your hip, your knee, your shoulder, your elbow, your fingers, etc. All right, so fibrous joints do not have that synovial cavity that we just talked about. Basically, we have articulating bones held together with dense tissue that's fibrous connective tissue. Little to no motion. Some examples, again, sutures and interosseous membranes, like the ones that hold the radius and the ulna together. Some examples of fibrous joints, right? This is a coronal suture. It's going to hold together the frontal bone and the parietal bones, right? And we have the outer compact bone, spongy bone, and inner compact bone on the normal areas of bone. But where the coronal suture is, we have mainly just the outer compact bone. So it's actually going to be more dense at a suture region than it is in the other regions. And we also are going to have ligaments in this place, sutural ligaments, which are there before the sutures are formed. And that's going to allow for a little bit of motion at those sutures, right? Another example of fibrous joints going to be here between the fibula and the tibia. Here we have some interosseous membrane. So it's called syndesmosis between the tibia and the fibula, and that's at the distal tibiofibular joint. We also have, so you might not think of this as a joint, but there is a joint between the tibia and the fibula. Another example would be the gymphosis, which is another example of a syndesmosis. And that's here between the tooth and the socket of the alveolar processes. So the alveolar processes are what's going to come up in the jaw. It's going to connect directly with the tooth, and hopefully that's all covered with gum. But either way, this is considered a socket as well, considered a joint as well, even though there's no motion anticipated here. Cartilaginous joints also lack synovial cavity, and they're held together with tissue that's connective and cartilaginous. Permits a little bit of motion, but not very much motion. Some examples are synchrodroses and symphyses. Here's an example here, epiphyses, right? The epiphyses and the diaphyses are separated by that epiphyseal growth plate, and we talked about that when we talked about bone tissue, and that actually is considered to be a joint, right? It's a joint between two different parts of the same bone. Or, for example, the pubic symphysis is going to be, here's a symphysis. This is where we're putting together these two regions of the pubic bone, and we do have a little bit of motion here, but not much. All right, synovial joints are what you think of when you classically think of joints. They have a synovial cavity, and it's when articulating bones are covered with cartilage, then held together by multiple ligaments. Inside, we have synovial fluid inside that cavity. They also have a nervous system, blood supply, and they have an articular capsule. And these are going to permit the largest range of motion. So here's an example of a synovial joint. If we're going to take just a frontal plane, so we're going to do a cross section through this finger here, so we're looking directly at the finger knuckle. Here we have the articulating bone A and articulating bone B, right? And in this case, these are phalanges bones, and they're going to articulate with articulating cartilage. So we have articulating cartilage here, which has the articulating cartilage membrane that is going to line directly with the articulating bone, and the synovial membrane right there. Inside of that, we're going to have synovial fluid. And then around that, we have a fibrous membrane that's going to connect these two together. So that's going to prevent these two bones from grinding against one another, but it is going to allow them to articulate or interact and work well together. Here's the actual dissected tissue of the frontal section of the phalanges. Again, here's articulating bone A and articulating bone B. Here we have the synovial or joint cavity, which is normally filled with synovial fluid. We also are going to have a membranous tissue that here is connecting from one side to the other. Here's the synovial membrane, and here's the articular cartilage right in there. All right, so we also can interact with things called bursa and tendon sheaths. So what are bursa? Bursa are little structures that are sac-like, that are filled with synovial fluid, and their objective is to cushion motion as the body parts move one along another. And tendon sheaths are tube-like, but they're still similar to bursa. They're tube-like, and they wrap around tendons that are going to be subjected to a great deal of friction. So in this way, they are protecting areas of the body that undergo a lot of motion and also undergo a lot of stress. All right, so for example, right, here's your carpals. Your carpals, which are your wrist bones, allow you lots of different range of motion, right? You can move left and right, you can move up and down, you can flex your hand one way or the other. So your carpals allow you to move your hand in a lot of different ways by gliding along one another in multiple different directionalities. All right, so here's some other types of motion, and these are going to be words that you should know. These are words that are all testable. So for example, we want to know what is extension, what is flexion, what is hyperextension, right? So in the case of your cervical intervertebral joints, which would be your neck joint, right, we can have extension, which is this direction, which is just going to be your normal standing. Hyperextension is further, and flexion is bending forward. At the shoulder joint, hyperextension would be reaching backwards. Extension would just be bringing it down to a normal anatomical position, and flexion would be up. So flexion would be raising it, extension would be lowering it, and then hyperextension would be further than that. So basically what we're doing, we're looking at flexion and extension. We're talking about bringing it in one direction and then bringing it back to what we consider to be normal positioning for anatomic norm, and then hyperextension would be in the other direction. So again, flexion, extension, and then, hyperextension doesn't work at the elbow joint. Hyperextension would be awkward, but at the shoulder joint it works. Same thing with the wrist. Flexion, extension, hyperextension would be bending all the way downward. Same thing with the hip joint. Flexion, extension would be returning back to anatomic norm. Hyperextension, all the way back behind. Same thing with the knees. In this case, flexion would actually bring you backwards and extension will bring you forwards. And same with the elbow joint, we don't have hyperextension, or we oughtn't have hyperextension. Hyperextension would actually be a pathological condition if we're looking at the knee and the elbow. If we're looking at the vertebral joints, we can have lateral flexion on one side or the other as well. So flexion just means what happens when you pull the muscles tight, what happens to the bones, right? So here we have abduction and adduction. So abduction is going away from the, so ABD, away from the body, ABD, away body. Adduction, you're headed back towards the body, adding back to the body mass. So abduction, away body, adduction towards the body. So with the shoulder, abduction would be raising your arm, and lowering it would be adduction. With the wrist, abduction would be bending it away from the body, and then adduction would be bending it back towards the body if you were an anatomical norm. Same thing with the hip joint, abduction away from body, adduction back in. Same thing with the fingers, if you extend them, that's bring them out into like a high five, that's abduction. If you bring them all together, again, adduction. So those are different types of motion at synovial joints. We also can have circumduction at the shoulder joint and the hip joint, and that basically is because we have ball and socket joints, we're able to make larger motions. So circumduction is basically making a rotating motion at the shoulder or at the hip joint. We can also have rotation of the neck or of the arms, etc., so of the legs. So rotation would be towards the body is medial, and away from the body would be lateral. Okay, so we could have lateral rotation if we're moving outward, medial rotation if we're bringing it inward across our chest. Same thing with our leg. Lateral rotation would be turning our toes outward, and medial rotation would be turning our toes inward. At the temporalmandibular joint, which is our mouth joint, right, we can have elevation and depression, so we can have it raised or lowered, and we can also have protraction and retraction. We can push it forward and pull it backward. This is very important for the process of chewing and for speech and swallowing. In our intertarsal joints, we can have inversion or eversion. So if you pick your ankle, right, pick your foot, and you move your toes inward towards it and bring it upward, inward and upward, that's inversion. If you move your toes outward and upward, that's eversion. At the ankle joint, we can also have dorsiflexion or plantar flexion. Dorsiflexion would go upward, plantar flexion would go downward. And in the radial ulnar joints, which would basically be like the elbow joint, right? We can change our hand to be, well, it's not really, it's the way that the radius and the ulnar roll over one another as you change your wrist positioning. And then we have supination, which would be your palm anterior. And protonation would be your palm posterior. So supination would be if you were begging for food. Protonation if you've got your hand down towards the floor. Pronation, I apologize. We also have the carpometacarpal joint, which allows us to bring our thumb and our fingers together in opposition. We can do this with any one of our four fingers, and that's in the carpometacarpal joint. All right, so just to kind of summarize the different types of motion that we can have at these synovial joints, we can glide back and forth or side to side, which is without changing the angle of the bones too drastically. We can also have angular motion, including flexion, extension, hyperextension, abduction, adduction, circumduction, all the things that we just talked about. In addition to that, lateral flexion, which is basically when we were talking about being able to pull the spine to one side or the other, so moving the trunk in the frontal plane from left to right. Additionally, we can have rotation movement. That basically can be around the longitudinal axis on your limbs, so you can either bring it towards the midline or away from the midline, so you can either have, like I said, medial or lateral rotation. And then we have specialized motion that occurs at specific joints, such as elevation or depression, protraction and retraction. We talked about that with the jaw. Inversion and eversion, we talked about that with our feet. Dorsiflexion and plantar flexion, supination and protonation, and opposition. All of those have to do with your feet and your forearms and your hands. All right, so there are multiple different types of joints if you classify them in a structural or in a functional classification. All right, so we can have a planar joint. A planar joint is when we have articulated surfaces that are flat or just slightly curved. And that is for some biaxial diathrosis. And diathrosis, again, means freely movable. And so if you see, I'm just kind of reading across here. And that means that they can go back and forth and side to side. We also have some triaxial diathroses, which can go back to forth, side to side, and rotation. Some examples of planar joints: intercarpal, intertarsal, sternocostal between the sternum and the ribs, and vertebral joints. So if you picture that you can move your carpals any direction, right? Or your intertarsals almost any direction. Same thing with your vertebral. You can go left, right, up and down, right? So you have multiple planes of motion that are freely movable on these planes. We also have hinge joints. Hinge joints are when we have one convex surface fitting into one concave surface, and that generally allows us to have a uniaxial diathrosis. Again, that is freely movable but only in one direction, such as flexion extension, like your knee, for example, which is a modified hinge joint that allows for a little bit of left to right, but really mainly flexion extension. Your elbow, ankle, and interphalangeal joints. Some other types of joints would be your pivot joints. Pivot joints are classified by being rounded or pointed surfaces where we're fitting directly into a ring. And these are usually uniaxial, meaning one directional diathrosis, such as rotation. So some examples would be your atlantoaxial and your radial ulnar joints, allowing just the one pivot, right? It's only able to go from up down, right? Let's see, we also have condyloid. Condyloid would be when we have an oval-shaped projection that fits specifically into an oval-shaped depression. And this usually is for biaxial diathrosis, so for things that are able to go in two directions at once, flexion and extension versus abduction adduction, for example. Examples of this include your radiocarpal joints and your mediocarpal phalangeal joints. Saddle joints is a very special type of joint. This is the articular surface of one bone is saddle shaped, and the other bone is kind of sits right in the middle. And this really is specific to this one joint, the carpometacarpal joint between the trapezium and the metacarpal of the thumb. And this allows for multiple different axes of motion, right? Biaxial diarthrosis, which flexion, extension, and abduction and adduction, and any combination of those allows for full rotation of your thumb. And if you caught yourself right now rotating your thumb in full socket, don't worry, I just did the same thing. All right, so ball and socket joints is when a ball-like surface fits into a socket or a cup-like depression. And these are going to allow you a great range of motion. So usually these are your triaxial diarthroses. They allow for flexion and extension, abduction and adduction, and also rotation. And some examples of this, well, the examples of this are going to be shoulder and hip sockets. All right, so what do I mean by all of this? I know I just threw a lot of stuff at you, but I'm going to tell you what I just told you on the previous slide right now in a little bit more detail. So this is a planar joint or a plane joint. Plane joint is an example here is between the navicular and the second and third cuneiform of the tarsus and the foot. So that's right here, navicular. And that allows us to either go left, right, up, down, or turn, right? So we can either biaxial or triaxial. You have a lot of range of motions at a planar joint. Here's a hinge joint. The hinge joint is only going to allow one range of motion, right? And so here we have the trochlea of the humerus interacting with the trochlear notch on the ulna, allowing for uniaxial, so one direction of motion. All right, here we have the ulna and the radius and the head of the radius that are all connecting. Here's the radial notch. And this is basically going to be the pivot point between the head of the radius and the radial notch of the ulna. Right, and that's going to allow us to have multiple different range of motions. This is in the wrist, if you guys are curious, right? The elbow would be this way, and this would be the wrist. This is here we have the uniaxial range, but it's going to be a rotational option. Right, so you can turn that like left or right, etc. So rotationally. We also, here's a biaxial range of motion, the condyloid joint between the radius and the scaphoid. So the radius and the ulna come together at the wrist to meet up with the scaphoid and the lunate, right in the top row here of the carpals. And that's going to give us biaxial range of motion, right? Left, right, up, down, gives us more than one. Now here's the saddle joint that I was just talking about, and this really is the only saddle joint that you're going to need to know because it's the only one that we know of. And that allows for multiple ranges of motion, even though it only allows for left, right, and up, down, because that allows, because of all of the combinations of upright or up, down, left, right, you're still going to be able to get full rotational motion. And that's again going to be between the metacarpal of the thumb and the trapezium of the carpals. Another example here, ball and socket joint. So here's the acetibulum of the hip bone, which we just talked about when we talked about the appendicular skeleton. And here's the head of the femur interacting directly with the acetibulum. That allows for multiple range of motion. It's triaxial. What that means is that we can do adduction, abduction, we can do extension and flexion, and we can do rotation. And any combination of those two allows for almost complete range of motion at those joints. All right, so what are the factors that affect the range of motion and the contact of the bones at the synovial joints? And that generally comes down to structure and shape of the articulating bones, as well as the arrangement of the muscles and the ligaments, and the contact of the soft parts. Additionally, disuse can lead to wear and tear, and hormones can increase or decrease the flexibility in these regions as well. So let's talk about some of the selected joints in the body. So let's start with the temporalmandibular joint. Well, what is that? That's the jaw joint. That's when you open your mouth. This is what is responsible for it. So here's the zygomatic bone, which interacts directly with the temporal bone at the zygomatic process, right? So this is at the very edge of your cheekbone, headed back towards the back part of your jaw. This is the lateral ligament and the articular capsule. That's all going to connect around the mandible. So the mandible fits right in here with all of these ligaments holding into place. We also have that styloid process that when we talked about the skull bones, you were probably like, what is that styloid process doing? Well, here we know. The styloid process has a stylomandibular ligament that connects directly off of the styloid process of the temporal bone directly to the mandible. And so that's going to allow for range of motion for the jaw. It's going to be the only bone in the skull that allows for motion if you disallow for the use of, say, the ear bones, which are going to be free-floating bones as well that are able to move. All right, so if we are looking here at the temporalmandibular joints, here we've taken a cross-section here through the sphenoid sinus, so we're basically looking outward from the inside of the head. There's a sphenoid bone, and then that connects directly to the articular capsule. Remember that articular capsule is going to be where the mandible is going to be interculating or articulating here with the temporal bone. We also have the sphenomandibular ligament and that stylomandibular ligament that we just talked about. Okay. Um, Here's a sagittal section. So if you're viewing it from the right side in a sagittal section, we have here the mandible that intercalates here at the articular disc with the mandibular fossa of the temporal bone. Okay, here's the auditory meatus where your ear would be, etc. Here's the condylar process of the mandible interacting directly with the mandibular fossa of the temporal bone, separated by this articular disc right here. It has a superior compartment and an inferior compartment, and it's a synovial cavity, and what that means is that there's synovial fluid inside of there, right? And again, here's that styloid process of the temporal bone where it's going to be connecting down to the mandible. All right, so let's move on to the shoulder joint. The shoulder joint is kind of complicated in that it has a lot of connections and a lot of connective tissue. So let's just dive right in here. So let's look at the bones first. So this is the clavicle. This is your collarbone, right? And then this is your humerus, and this is your scapula. Your scapula has that coracoid process that sticks out, and that's going to be very important because that coracoid process is going to interact here by the coracoacromial ligament to the clavicle, right? So we're going to have multiple different connections. We have the acromion of the scapula, which is a region that sticks off the edge of the scapula, and that's going to connect to the clavicle by the acromioclavicular ligament, which is here, and it's going to connect also here to the coracoid process by the coracoacromial ligament. We also have the coinoid ligament, which is going to connect, again, the coracoid process to the clavicle, but in a different location. That's here. And then the trapezoid ligament, which does the same thing, but again, from a different direction. So these two are both going to be connecting the coracoid process of the scapula directly to the clavicle. We also have this region here, the superior transverse scapular ligament, which connects one side of the scapula to the other. All right, again, this is the scapula. And now if we're looking at the actual connection, the connection tissue, we have some bursa here. The bursas are shown in blue. So here's a subacromial bursa that's going to be right underneath the acromia of the scapula. And then we also have the subscapular bursa right here, which is just going to be right around what's called the articular capsule. Okay, so we've cut through here the tendon of the subscapularis muscle just so that we can kind of have a visual on what's happening behind it. But that's going to be here. We have a cross section. Now, some other ligaments that we have, remember ligaments are going to connect the bone to bone, right? And so this ligament here is the glenohumeral ligament. And tendons are going to connect muscle to bone. So this is the tendon of the subscapularis muscle. All right, this is the coracohumeral ligament, which is going to connect the coracoid region, right, to the humeral bone, right? And we also are going to have the glenohumeral ligament here, which is all again going to be connecting. So let's see, what else am I missing? Here's the transverse humeral ligament, which goes across the humerus. And then this is the tendon of biceps brachii. So this is the tendon of the biceps that are also going to be coming in and connecting at that same region. All right, so now I'm going to take you through a cross section. All the same things I just showed you, except now we're looking at a cross section in a lateral view, and it's opened up. What do I mean by opened up? What that means is that we have removed the humerus, basically. All right, so we're just looking at directly in as though the humerus is not in the socket. All right, here's the acromion of the scapula with the coracoacromial ligament. Again, that's going to be connecting the acromion to the coracoid process of the scapula. Here's the coracohumeral ligament, which is connecting the coracoid process of the scapula to the humerus. Here's a tendon of the supraspinatus muscle. Here's a tendon as well of the biceps. Here's a tendon of the subscapularis muscle. So all these tendons are all coming together. And then again, ligaments are going to be connecting bone to bone. These are glenohumeral ligaments coming together here. This region is called the glenoid labrum. And inside that we have the glenoid cavity. And this is the region where the ball, this is the socket, right? This is where the ball of the humerus would actually be interacting. Here we have the tendon of the infraspinatus muscle. And this whole thing is going to be the articular capsule that covers the whole outside. Here's another tendon of the teres minor muscle. So we have a lot of tendons and a lot of ligaments all coming together in this ball and socket shoulder joint. All right, so if we take a frontal plane, we're basically doing a cross section and opening it up, looking directly through the frontal section. Here we have the acromion of the scapula again, just to orient you, and then that's going to go from the acromial clavicular ligament over to the clavicle. So this ligament links the acromion and the clavicle. Here's that tendon of the supraspinatus muscle. Again, that's coming right in underneath that subacromial bursa. So we have the acromion, the subacromial bursa, and then the tendon of the supraspinatus muscle coming in right there. Then we're going to end up with the articular capsule. That's here. The articular capsule is going to basically be where we are articulating the head of the humerus, right, directly with the scapula itself. This region here, glenoid labrum, those are going to be regions that are going to be right outside of the scapula. That's going to line up with this articular capsule. The articular capsule, just like most articular capsules, are going to have synovial membrane with synovial fluid inside, right? We also have fibrous membrane here directly outside of that. So here's our synovial membrane and our synovial cavity. And last but not least, we have another tendon. Here's the tendon of the biceps, which runs right into, these regions are called the tendon sheath, so it's going to go on either side of the tendon. So we actually have an articular capsule on the outside and also on the inside of the tendon of the biceps. All right, so what does that look like on an actual cadaver? So here's a frontal section of a cadaver, and so we're going to see all of the same things instead of it being an image. However, it's actually a cross section. Here's the acromial clavicular ligament, which connects the acromion to the clavicle. Right, here's the supraspinatus muscle, which runs right underneath. Then we also are going to have the bursa right here, which I assume they're not showing us. Here's the glenoid labrum here, and the glenoid labrum here, all surrounding that articular capsule. Here's the articular capsule, which has two sections because we have that bicep tendon running right on in as well. Here's the tendon sheath. So we have the articular capsule on this side, and then on that side as well, here's the head of the humerus, which is articulating directly with the scapula right here. All right, so that's what you're actually looking at if you're looking at a cross-section in a cadaver. So let's move on to the elbow joint. All right, so the elbow joint is connecting the humerus to the radius and the ulna, right? And so the humerus has multiple different ligaments that are connecting here, including the annular ligament of the radius, which runs across the radius. Remember, ligaments are connecting bone to bone, and tendons are connecting muscle to bone. So here's a tendon of the biceps brachii. That's going to be connected right here to the radius, and that biceps, as you may remember, runs up the entire humerus, and when we flex it, we can pull the radius up to the humerus. Here's the ulna and the olecranon of the ulna. Behind that, we have the olecranon bursa, which is just like a little sac that helps protect it. Here we have the articular capsule, which is right here, and around that we have ligaments. Here's the ulnar collateral ligaments there. All right, if we look at the lateral, oh goodness gracious, sorry. If we look at the lateral version, here's the humerus, again the radius and the ulna. Here's the ulnar, the olecranon of the ulnar region. Here's the olecranon bursa. We also have the articular capsule around that, tons of ligaments. Here's the radiocollateral ligament and the annular ligament of the radius. Here's the lateral epicondyle. The medial epicondyle will be on the opposite side. And again, here's where the tendon, remember tendons connect muscle to bone, whereas ligaments connect bone to bone. And this is where the tendon of the biceps is going to be interacting with the radius. And this here, interosseous membrane. All right, so let's move on to the hip joints. So the hip joint is where the femur is going to be interacting with the hip bones, right? So here's the hip bone, and we have multiple ligaments. Remember, ligaments connect bone to bone. So we have the head of the femur into the acetibulum, which you can't see in here, of the hip itself. And then this here is a tendon which connects the rectus femoris muscle, but we've removed most of the muscles here just so you can see what's happening with the ligaments. Here's the iliofemoral ligament, just exactly what you'd expect, connects from the ilium to the femoral region, right? Here's the pubofemoral ligament, connects from the pubis over to the femoral, right? We also, inside that large canal, that obtural canal, we have an obturator membrane as well to help kind of hold that in place. All right. So if we look from the posterior view, we can still see that iliofemoral ligament, which is connecting the iliac area to the femoral region. Here's the opposite side of that rectus femoris muscle that's been dissected away. There's a greater trochanter of the femur. We could see that before as well. Greater trochanter and lesser trochanter of the femur. Lesser trochanter here, all running down into the femur itself. And again, these ligaments are all going to be connecting the femur bone to the hip bone. So the ischiofemoral ligament is connecting here. And then this region is called the zona orbicularis, which allows you to have rotation of motion, right? So it's an area that allows you to orbit. All right, if we do a frontal section of the hip joint, so basically taking a cross section and now we're looking straight back in from the front. Here's the hip bone. The hip bone is connected to the femur by the head, right, and located in the acetibulum. This is the acetibular labrum right here. And this here is articular cartilage. That articular cartilage has a synovial cavity, just like all articular cartilage, and that synovial cavity is filled with synovial fluid. This ligament here is going to be the ligament to the head of the femur. We also have another ligament here, the transverse ligament of the acetibulum, which is going to be connecting from the acetibulum transversely to another region of the acetibulum. Here's the zona orbicularis right here. Sorry. This is going to be an area that's going to be this allowing for a great range of motion. Here's the bottom of the hip bone. And then here again, zona orbicularis to allow it to be able to, basically going around the whole head of the femur here. Here's the lesser trochanter of the femur and the femur itself. All right. Without any further questions, we'll move on to the knee joint. So the knee joint is obviously going to be connecting the femur to the tibia and the fibula, and we also are going to have the kneecap involved in terms of bone positioning. So here's the femur. We have the lateral condyle and the medial condyle of the femur. We also have the epicondyle and the lateral and medial epicondyle, which are not shown here. We have the ACL and the PCL. You may have heard of this. These are going to be ligaments. Again, ligaments connect bone to bone. So the ACL and the PCL are going to be anterior and posterior cruciate ligaments. This is what happens when people have pivotal injuries, like generally football or tennis, where they are running from one side and then they quickly turn to pivot to go to the other direction and they just end up tearing through usually the ACL. And the ACL and the PCL are going to be connecting the regions of the condyles, so the lateral and the medial condyles, to the tibia itself. All right, this here is the meniscus. It's going to be a region in the knee that has a little bit of a fluid layer. It's going to allow for articulation of these bones without them actually grinding on one another. It's going to be connected directly to the transverse ligaments of the knee, right? So these are going to connect to the meniscus. We also have other ligaments that are going to connect. This is the fibular collateral ligament. It's going to connect the fibia and the tibia. And then this here, this is going to connect the fibia and the femur. The fibular collateral ligament connects to the femur, not to the tibia. And the anterior ligament at the head of the fibula connects to the tibia, all right, connects to the tuberosity of the tibia. This here is the tibio-collateral ligament. Again, the collateral ligaments run around the outside and connect to the femur. So we have the femur connecting here to the fibula by the fibular collateral ligament, and the femur connecting on this side to the tibia by the tibial collateral ligament. And if we do a superior view of this, so here's the posterior and the anterior, and we're basically looking upward. We're looking downward from the superior region, so we're looking down. Here's the patellar ligament, which is going to connect to the patella being the knee bone. Here's the ACL. It's been cut, but again, the ACL and the PCL are going to connect inwards from the tibia to the lateral and the medial regions of the condyle of the femur. So they're going to cross each other. Here's the posterior, so the PCL and the ACL are going to cross each other. They've both been cut. Here's a lateral meniscus. Here's a medial meniscus. Those are being connected by these ligaments here. And we also have some ligaments that are the collateral ligaments, the tibio-collateral ligament, and the fibular collateral ligament, which have been cut in cross-section because we are looking down, right? But those are going to connect both the tibia, this one, and the fibula to the femur. All right, so if we look at a sagittal section, so we're taking a sagittal plane here, we're basically cutting right through the knee, and we're looking inward from one direction to the other. Here we have the femur interacting with the tibia. We also have the patella, right? And we have here this bursa. This is the suprapatella bursa. We have an infrapatella bursa and a prepatella bursa. So we have a lot of these little bursa which are meant to help support and help prevent injury to the patella and other knee regions because the knee is going to be taking a lot of stress. This here is a tendon that's going to connect the quadriceps, down to the patella. And then here we have the patellar ligament, which is going to connect the patella down into the tibia. There's a lateral meniscus on this side and on that side. And then here we have the actual synovial cavity itself. We have articulating cartilage on this side and on that side. All right. So what does that look like? Here we have the tendon of the quad muscle, just like we were seeing here. We also have the suprapatella bursa here, the prepatella bursa here, and the infrapatella bursa here. We have the patellar ligament, again, which is going to connect the tibia to the patella. And on the top, it's going to be the patella is going to be connected to the quads, right? And then, or quadriceps, I apologize. And then here we have, again, this is the femur articulating with the tibia. And there's the medial meniscus here and there. And then we also are going to have this set of muscle, semimembranous muscle, that's going to be running along as well. And then there's the gastrocnemius muscle running along there as well. Okay, so that's a overview of the knee joint from the cross-sectional view. So let's look at the superficial views for both the anterior and the posterior. Well, I guess the posterior is more of a deep view. All right, so the anterior view. So here we have the femur. Again, it's intercalating or articulating, I apologize, with the fibula and the tibia. And the patella is also a bone that's going to be involved here. So the patella is connected here to the quadriceps by a tendon, and on the bottom by a ligament to the patella. That's the patellar ligament. Right? These here are going to be the vastus lateralis muscles. Behind that we have the suprapatella bursa and then the femur. On this side we have the lateral patellar retinaculum. And then here we're going to have the medial patellar retinaculum. Behind that we have the tibia collateral ligament right here. Again, that connects the tibia directly to the femur. And then we have the fibular collateral ligament, which is going to connect up to the femur as well. And don't forget that the fibula doesn't interact directly with the femur. It's just going to interact here with the tibia. So those are going to articulate there as well. All right, so if we remove a little bit, so we remove, for example, the kneecap and some of the muscles. So now we see the femur. This is the posterior view. So I want to say we removed the kneecap, but we didn't. We're looking from the opposite direction. So the kneecap's actually from the opposite side. So the posterior view, we're looking at the back of the knee here. Here's the femur. And then this is the tendon of the adductor magnus muscle right there. This is the head of the gastrocnemius muscle. This here is the plantaris muscle and the lateral head. So we have the medial head and the lateral head of the gastrocnemius muscle. This is a ligament that's going to be the oblique popliteal ligament. Popltea means relating to the knees. We're going to have the arcuate and the oblique popliteal ligaments that are going to be, again, ligaments connect bone to bone. And they're both going to run right across here and down there. That's going to connect the femur across to the tibia and then also down into the fibula here through the arcuate popliteal ligaments. So that's how the knee is going to connect to both of the lower bones. We also have the popliteus muscle here. It's been cut off so we can show all the ligaments underneath here, and the semimembranous tendon is going to be here, and that's going to run up until this muscle there. All right, so again, this is the tibia and the fibula, so I feel like we've touched on mainly everything there. So this is what a knee joint looks like in an actual cadaver. So here's the femur, here's the tendon of the quadricep muscle, here's the patella, which is hidden by the by all the tendons here. Here's the articular capsule right there. Here we have the lateral meniscus, and this will be the medial meniscus, but you can't really see it. Here's the patellar ligament, which again connects the patella down to the tibia. Here's the fibula connected to the tibia right there. And then if we look at it from the posterior view, so we're looking from the back, again, here's the femur, here's the articular cartilage of the femur. And then here's the ligament. So here's the ACL and the PCL. Again, those are kind of crossing each other that are connecting the femur to both the tibia and also to the fibula. Here's the collateral ligament that's going to connect the tibia and the femur this direction, and here's the collateral ligament for the fibula. So it's the fibular collateral ligament. Again, that's connecting the fibula and the femur directly. Here we have the popliteal ligament. It's been cut off so you can see other things. And then here's the posterior ligament of the head of the fibula. All right. So now that I've gone over the joints, let's talk about what happens when joints go awry. So as we get older, our joints, which are constantly under stress, end up producing less synovial fluid and end up with thinner articular cartilage. They also end up losing the length of their ligaments, so ligaments end up a little bit shorter with less flexibility, so we end up basically setting ourselves up for injury because we end up with weaker joints. And as we get to the point where our joints truly fail us, we can replace our joints with a surgery called arthroplasty, and that will help counter the effects of aging. So here's an example of a arthroplasty for a total hip replacement. So they're going to keep the shaft of the femur, and they're going to keep the hip bone. But what they're going to do is they're going to remove the head of the femur. So they're going to grind this right on down, and then they're going to put in an artificial hip joint. So this is what the artificial hip joint looks like prior to implantation. It has an artificial acetibulum right? And that acetibular should normally be part of the hip already, remember? So that's actually going to be the hip, not the ball, so the socket. So they're actually going to be reshaping the acetibulum to be able to put this right in, give it an artificial acetibulum and an artificial femoral head. So these guys are going to basically be its own ball and socket. And then this metal shaft is going to get driven down into the shaft of the femur and secured by screws, right? So the hip bone is going to be reshaped so that we have a region where we're just going to be allowing this fake acetibulum to align. And then instead of having a head of the femur, we're going to have an artificial femoral head. And that whole thing is going to go right down into the shaft of the femur, allowing for returned or restored range of motion for someone who has had failing hips. Now, what do they do for the knees? All right, so this is arthroplasty for a knee replacement. Here we're having the patellar surface has been removed, the femoral surfaces have been shaved down, and the tibial surfaces have been removed as well. Why do they do that? Well, we have to add these pieces back in. So we're going to shave it down until this femoral component pops right on top of the femur. And the tibial component is going to have a little plastic spacer that interacts with the femoral component. You can see how that would interact with this. And it also has a region that's going to tap right down into the inside of the tibia. So we're going to have that attached by screws. And then the patellar component is going to replace the kneecap. So instead of having a kneecap, you're going to have an artificial kneecap, this patellar component. They're going to try to save as many of the ligaments as possible if they can, and just replace the kneecap with the patellar component. The femoral component will be replacing the femoral surface, and the tibial surface will be replaced by this tibial component. And so this is what it looks like when it is implanted, as opposed to what it looks like when we have it in pieces. So this is what you can look forward to as you get older. And good news is every generation these get better and better and better, to the point where now people don't even limp, and they claim that they should have done it years ago because it feels so much better than their original failing joints. So anyway, I appreciate you guys sticking with me to the end of that lecture. So mahalo and happy studying. Aloha.